So, what were they trying to do? Basically, my article's researchers wanted to see if there could be any visible, quantifiable, significant effect in supplementing lactin V via vaginal self-administration following a full course of metronidazole for prevention of relapse BV infections. What they did to screen, the researchers screened premenopausal women between the ages of 18 to 45 for eligibility. This screening included getting a patient's medical history, as well as physical and pelvic exams. So if a potentially eligible woman met at least 3 of 4 AMSL criteria, which are basically which are four general things that are looked out for, including thin, white or yellow homogeneous discharge, greater than 20% of clue cells on microscopic examination. And clue cells are epithelial vaginal cells that are covered in bacteria. They have a distinct appearance to them. Vaginal fluid with a pH that was greater than 4.5, and a release of a fishy odor when 10% potassium hydroxide was added to a vaginal specimen. A vaginal swab was obtained and sent to a central lab, and gram staining of the vaginal smear was used to determine the Nugent score, which is a gram stain scoring system used to diagnose BV. So 0 to 3 is considered normal, 4 to 6 is considered intermediate, and 7 to 10 is indicative of bacterial vaginosis, BV. This was a very comprehensive and intensive screening because they also tested potential participants for HIV, syphilis, gonorrhea, chlamydia, trichomonas infections, and UTIs. All the women who went through the screening process had already, within 30 days, undergone a full 5-day course of 0.75% metronidazole for their initial BV. After concluding that metronidazole was when they came back for continued screening to test for those other infections I mentioned. So once the women did all of that, including meeting at least 3 of the AMSL criteria, a Nugent score between 4 to 10, have gone through the metronidazole, tested negative for the STIs, they were then randomly assigned in a 2-to-1 ratio to receive lactin V at 2 to the 109 CFU per dose, or matching placebo, and subsequently received a carton containing 25 vaginal applicators. And the placebo formulation contained the same inactive ingredients as the lactin V, just without that L. crispatus CTV-05. Now, adherence to the treatment was self-reported by the participants and by the staining of those returned applicators, organized in pre-labeled pouches provided for each week. Treatment adherence was part of the review of the blinded case review committee. And that adherence was defined as having taken at least 4 of the 5 doses during week 1, and 75% of total doses required per protocol, which allowed skipping or delaying a dose during menstruation or BV retreatment during weeks 2 to 11. At the 4, 8, 12, and 24-week marks, participants had follow-ups. That's where they checked to see if there were any relapse, and that's when subsequent retreatment and the allowed skipping or delaying of a dose would occur. Each time that they had the follow-up, vaginal swabs were obtained for assessment of that AMSL criteria. They got a Nugent score, and they went through a detection of L. crispatus. This includes all strains and also specifically for the CTV-05 strain by means of quantitative polymerase chain reaction PCR assays. The swabs were also used for repeat STI screen testing if clinically indicated. A positive L. crispatus result was defined as a level above the lower limit of detection for both the assay for all strains and the assay for the CTV-05 strain. The researchers estimated that with a sample of 228 participants, the trial would have 70% power to detect a The researchers estimated that with a sample of 228 participants, the trial would have 70% power to detect a cumulative percentage of participants with recurrence of bacterial vaginosis by week 12 that was 50% lower in that lactin V group than in the placebo group, using Pearson's chi-square test at a two-sided alpha level. This calculation was based on an anticipated dropout rate of 10% in the complete case analysis population and an assumed cumulative percentage of participants of the placebo group with recurrence of bacterial vaginosis by week 12 of 30%. The researchers calculated the cumulative percentage of participants who had a recurrence of bacterial vaginosis by the 12-week and the 24-week visits in each treatment group, as well as the risk of ratios and 95% confidence intervals. Pearson's chi-squared test was used to test the null hypothesis that the cumulative percentages of participants who had a recurrence of bacterial vaginosis by weeks 12 and 24 in the lactin V group would be equal to those in the placebo group with a two-sided alternative hypothesis. For the intention to treat and modified intention to treat analyses, when diagnoses of bacterial vaginosis were missing, the data were imputed with the use of two single imputation methods, one of which was the last observation carried forward. Post hoc sensitivity analyses for missing data were performed to calculate the risk ratios and corresponding confidence intervals. The hypothesis tests were performed with the use of logistic regression multiple imputation under the assumption of a monotone pattern of missing data. Now, let's talk about the results. Going back to treatment adherence, we discussed how they defined adherence, but here are the results calculated by the researchers. Adherence to assigned treatment was 81% according to participant report and 77% according to the number of applicators that had positive staining in the lactin V group, as compared to with 79% according to the participant report and 74% according to the number of applicators with positive staining in the placebo group. Let's take a look at figure 2 from the study, right here. It covers the median concentration and incidence of detectable Lactobacillus crispatus CTV-05 in the lactin V group according to the trial visit. The bars indicate maximum and minimum values. The horizontal lines inside the blue bars indicate median values, and the diamonds indicate mean values. The circles below the blue bar at week 4 represent outliers. The size of each blue bar represents the interquartile range. CFU denotes colony-forming units. So their primary outcomes include, among the 228 participants who underwent randomization, the status of recurrence of bacterial vaginosis was known for 197 participants, 86%. In that intention to treat population, recurrence of bacterial vaginosis by week 12 occurred in 46 participants in the lactin V group, which ended up accounting for 30% of that group, and in 34 participants in the placebo group, which ended up accounting for 45% of that group. And this is all referred to in Table 2, which is titled The Bacterial Vaginosis Recurrence Status in the Intention to Treat Population. Among the participants without known recurrence of bacterial vaginosis by week 12, a total of 13 of 106 participants, 12%, in the lactin V group, and 7 of the 42 participants, 17%, in the placebo group had a recurrence by week 24. Let's discuss. So, there was a significant difference between the groups that were studied in this paper, with favorable outcomes for the participants that were in the lactin V group. Definitely at the week 12 mark, and some of those effects even stayed through to week 24. While not perfect numbers, it's definitely a starting point for this kind of research. In addition to live biotherapeutic products such as lactin V, other products and strategies have been tested to determine their effectiveness in reducing the risk of recurrence of bacterial vaginosis. These include intravaginal metronidazole at a dose of 750 milligrams, plus miconazole at a dose of 200 milligrams, boric acid, and most recently, vaginal microbiome transplantation. Although combination metronidazole probiotic regimens have been tested previously, and some have been shown to reduce the risk of recurrence of BV, the trials have generally been small and have lacked the use of standardized methods, including objective outcome measures for BV recurrence and colonization by the active trial medication. The authors also indicated that they were in the middle of a phase 2, as it were, of this study. And here's what they had to say. The results of their phase 2 trial, phase 2A trial, raised the possibility that exposure to semen during sex without the use of a condom, the presence of menstrual blood, the reestablishment of bacteria associated with BV soon after completion of antibiotic treatment may reduce the colonization of L. crispatus after administration of lactin V. This is in the intent to treat population, of course. In the current trial of their phase 2A, the initial dose of lactin V or placebo was administered within 48 hours after the last dose of vaginal metronidazole gel, and the frequency of dosing after the first week was increased from once weekly to twice weekly through week 11. They did not find that the occurrence of menses since the last visit or the occurrence of sex without the use of a condom affected the detection of lactin V. So, turning the attention back onto you now. Here are some questions to open up discussion. I'd love to hear from you all. So, what were some of the limiting factors of the study? Our researchers discussed how studies before them were lacking in sample size and length of study. Did you think, what did you think about their group size? What about the sizes of their randomized groups? Did the ratio 2 to 1 seem like a limiting factor to you? Should it have been more equal? Let me know. What about the length of the study? Did you think that 24 weeks is too long, too short? What would you do if you had your own lab to continue this research? What stands out to you as logical next steps in this exploration? If you were a part of this initial research group, and as we know, they're in their phase 2A, if you were in that group, what would your phase 2 be? Where would you continue and take this line of research? And finally, throwing a random one out there, let's think about the potential participants who didn't meet the criteria. What about them? Are they doomed to have recurring BV forever? Should there be eventually research that includes women who wouldn't have met the screening requirements for this experiment? What did you think of their screening process? It was obviously very comprehensive and very necessary and very thorough. But what did you think about it? Could it have been even more thorough? Could they have let some other things slide? Well, thank you so much for helping me deep dive into this article with you and deep diving along with me. This is just my references. This first one is the article we have been talking about by Dr. Cohen et al. And here are some of the other articles that I was mentioning before, or some of my background. And in What Do We Currently Know? That is that great big review article that I shouted out at the very beginning.